Hi, I'm Wayne Eskridge of the Fatty Liver Foundation. You're listening to Surfing the NASH Tsunami podcast.
Drug developers, investors, researchers, and corporate executives wrestle weekly to understand what is happening in commercial development of NASH medications. Join hepatology researcher and key opinion leader Stephen Harrison, C-suite veteran Peter Traber, and forecasting and pricing guru Roger Green as they discuss the issues affecting the evolving NASH market from their own unique perspectives on this week's edition of Surfing the NASH Tsunami.
For everyone with an interest in NASH, or more broadly, fatty liver disease, surf's up, because episode 19 of Surfing the NASH Tsunami starts now. Our teenage episodes end today. Next week, unbelievable, episode 20. Soon, we might even decide to go on to season 2. As we get started, a personal note, I'm podcasting today from my summer vacation in Cape May, New Jersey. Here's a shameless plug for Cape May, a truly iconic jewel at the southern tip of the New Jersey shore. And by the way, the place where my wife and I exchanged vows 20 years ago this coming October. We love it here. I'm working with less screens than usual, different acoustics, and no ability to take notes, so here goes. We have Stephen, Louise, and Donna with us today. Peter is settling his daughters into their college dorm room, the kind of thing that never runs on schedule and never is as much fun as it sounds like it's going to be, and it never sounds like it's going to be fun. That said, I would like to extend a warm welcome to another special guest. Wayne Eskridge of the Fatty Liver Foundation is counted, along with Tony Vigliotti, who joined us last week, and just a handful of others as leading patient advocates in the U.S., all of whom work with Donna. Wayne has quite a history, both as patient and advocate, and he'll tell you a little bit about all that and the work his foundation does in a couple of minutes. Moving ahead, notes on the cutover. Last week I said we had an audience in 6 continents. The audience has grown in all 6 continents in a week. That's a good thing. We also have over 10 people on our LinkedIn bulletin board in the first week. One of whom is Wayne. He was an early joiner. Thank you, Wayne. And I will be dropping by a couple times on vacation this week to say hi to new participants. I think Louise will be as well. And we will be seeking requests and perhaps doing some polling with you on upcoming episode concepts. So thanks to all of you who are telling your friends to stay engaged. Thanks to GLI, NASHTAG, CLDF, the others who keep spreading our message. And now, a last thing before we start, I'm going to ask Louise to talk a little bit about our music this week and where it comes from. Louise, it's yours.
Roger. And this week's music is a complete contrast from last week's. It's a piano recital, and it's by a gentleman called Jeff Ramsdale, who donated these pieces of music to the British Liver Trust as a fundraiser. So he has a Just Giving page, which you can go to, and via YouTube you can listen to the whole piece. But ultimately he had a liver transplant, and the British Liver Trust were of great support to him and his family. So he donated these as a fundraiser. So I'm certainly going to donate to his page, and for anybody who wants to, we'll have the links on Surfing the NASH Tsunami later on. So he'll play us out, and I hope you enjoy.
As Louise points out, we will have a link attached to the podcast player and on Surfing NASH homepage. With that, let's dive into this week's podcast. We're going to be talking about professional highlights this week, but before we do that, I'd like Wayne to start. Tell us a little about yourself, your history, experiences with fatty liver disease, the foundation, work it does, any recent professional highlights. All that in 2 minutes.
Okay, thanks, Roger. Well, my course was, as a liver patient, was disturbingly common. I was discovered incidentally in liver surgery, or gallbladder surgery. They took a biopsy at the time, and my surgeon told my wife in recovery that I had cirrhosis and I had maybe 3 to 4 years to live. Next day, I was surrounded by 3 doctors, and they were asking me all these questions about alcohol, and I was disturbed a little bit. All they really had to do was look at me. I was kind of an American fat boy. I'd gained a pound or 2 a year for 50 years. Very classic, not even mysterious. But I then went into the gastro process, lots of tests, lots of things, and in a few weeks the doctor said, well, there's nothing wrong with your liver. You're just fine. You don't need to see me anymore. And the pathology report said I didn't have any liver disease, but had this really ugly picture of my liver. And for 4 years, I carried my picture to all my docs and asked them about it, and I got lots of tests and never had anything happen. But in 2014, my blood iron went up, and so I saw a hematologist. He said that I was a cirrhotic and hemochromatosis. So 7 liters of phlebotomies later, I clearly wasn't because I crashed. But I got referred to a hepatologist, and like a lot of people in America, my hepatologist was 300 miles away. And we went through that process. He took one look at my pathology slides, and he said, well, you're a NASH patient. We'll do the test, but I'm sure you're cirrhotic. I was fortunate, very fortunate, because my hepatologist was not educated in America. He was from London. And he spent time with me. He told my wife and I how to approach this, what we needed to do, the things we needed to accomplish, and what was wrong. We flipped a switch that day, went home, turned our refrigerator and pantry out, threw everything away, and started over. A year and a half later, I was at my high school weight, and at diagnosis, my FibroScan was 21.5. 18 months later, it was 9.9. And I was the poster boy of the clinic because most of their patients don't do well. And in that process, I learned all the bad information that was out there that people had access to. Prompted us to start the foundation in 2017, and our goals are just to change the way medicine is practiced in America with regard to fatty liver disease and to help people avoid all that. I could spend the rest of your hour talking about things, but a little professional highlight. You're doing EASL going in. We're doing a webinar coming out with some retrospective on EASL, and Scott Friedman and Brent Tetry and Nadeg Gunn are going to participate with us, and I'm sure you all know all of them. So that, I don't know how long that was, but hopefully that'll take care of your 2 minutes.
This is Donna. I usually respond to calls for bravery. Tis true. It's really a success of my policy director, but since I hired him, I get to claim it. We advocated for a change in the ICD-10 codes related to NASH, and CMS did evaluate our evidence, and we want to thank Dr. Arun Sanyal for helping us with that. And so CMS did approve the change. And so there is better granularity to distinguish between early fibrosis and advanced fibrosis, where there wasn't that granularity in the codes previously. So hopefully that will be a help not only to clinicians and to patients wanting to document disease, and as various interventions develop for it, being able to get those to patients more easily with more support by payers. But it should aid health research in NASH as well, and surveillance and other activities in NASH with more accuracy. So I'm very excited. This is the first time we've put something through this type of CMS coding process, and to be successful in it, is very exciting for us to be able to do this on behalf of the field.
I'll go next. This week's positive was we started scanning again, which was excellent. We had no patients not turn up, which was another positive, and I'd like to congratulate Donna on that work, because the earlier we find it, the better. And I think we've always been looking with blood markers for higher stage fibro F3 and above. So now we can look for a bit earlier and get that, make that ICD-10 code work. Thank you.
Superb. Stephen?
First of all, let me say welcome, Wayne. It's great to have you on the podcast joining us today for this 19th episode, and anxious and looking forward to your comments. But I also want to foot stomp what you said about your hepatologist, because he is a unique individual, one of a kind, and probably one of the best in the business. So you were fortunate to have him and continue to probably have him as your doctor. As for me, a professional win was one of my patients this week who has been in a clinical trial for 1 year, came in as a stage 3 NASH patient with an ALT in the 90s and AST in the 70s, and glycemic control wasn't as good as it should be. 1 year of treatment later, in her FibroScan, just to backtrack, FibroScan had a cap of like 380 and a KPA somewhere around the 19 range. And just to bring it fast forward 365 days later, comes back, her liver enzymes are completely normal, glycemic control normal, kidney function even improved, and her FibroScan has a cap of 200 and a KPA of, I think, 8. So don't know what the follow-up liver biopsy shows because it's a study, but I can rest assured you it will be much better than what it is today. If we did patient-reported outcome measures, which we did not do, she would tell us that she feels 100% better, more energy, less fatigue, just a better person all around. Abdominal pain is gone, and that's why I do what I do, is to effect change, and that's what keeps me coming back day after day. It's an addiction. I'm sorry I have it. But I love that. I wish I could have that same story every day, and I'm hopeful that more and more of those stories will begin to come out as our therapies get better and better and better. And with that is my professional win for the week.
And not a bad tee up for the second half of today's episode either. Since I'm on vacation, I'm not supposed to have a professional highlight, but this morning while out shopping, I walked into a shoe store. Wound up in a conversation with the store owner, local merchant, talked about what are people to do to get through the pandemic. I said, well, I just look unusual. I started a podcast. He asked what it was about. I said, liver disease. And he spent the next 15 minutes telling me about his brother, his brother-in-law, and his best friend, who in no particular order had their gallbladder out and had to learn how to eat right, were diagnosed with fatty liver disease 6 years ago and kept them when they should worry about it. But he said the doctor said, don't worry. Third one wasn't able to eat a whole bunch of things anymore, but was insisting on substituting fat for fat, and the guy thought that had to be a bad idea. So we made a listener this morning from a shoe store owner who will now, or maybe 4, because he will now go tell 3 members of his family that what they can learn, they might be able to learn better podcasting an hour a week than they can just going their own blithe ways doing what they're doing. That was pretty cool. We have no questions worth spending time on this week, in part because most of the questions we've been getting are about, so what is this EASL coverage really? I will take a minute and talk about that before we get started. Next week will be EASL week here at Surfing the NASH Tsunami. Our regular weekly taping will appear Thursday afternoon, and it will be a preview of what we expect to be hearing during the conference, although by the time we drop it, the conference will already have started. Then, after close of presentations and papers on Thursday and Friday and Saturday, we will tape immediately, we will send to editing, and we will turn around in 7 or 8 hours and drop a show at 10 or 11 o'clock Eastern Time each night, or 4 to 5 the next morning, Central European Summertime, so that when you wake up in large parts of the world, or as you start your day and a couple of others, you'll be able to learn about what happened the day before at the meeting. I will add that after that, Wayne has what sounds to me like the perfect follow-up at the end, although it's not our event, it's Fatty Liver Foundation's event, bringing together some truly esteemed colleagues to talk about what happened in the event and make sense out of what was most important. Look for us every day next week. If you want to make sure to get a drop quickly, send us your email address or check it in at surfingnash.com. If you've got friends or colleagues you want to know about it, if you work in an office with other healthcare professionals and you want them to get that information quickly, tell them to send in also, and we will shoot you out links as soon as we drop every day so you can stay right on top of the meeting. And with that, we'll now kick into today's episode. So in episode 16, we talked about what the healthcare system does and does not do well enough, as seen by our panelists, which led to last week's episode, which was what does the healthcare system do well and not do well enough and could do better, as seen by patient advocates who happen to be patients. At the end of that conversation, it was interesting. The focus wasn't on give us better drugs, give us better diagnostics. Not that those aren't needed, but in terms of what can be done today, the focus was on better, faster, more accurate information on the disease, better support on self-care and self-management, and about how coordinated care within the healthcare system will lead to more complete treatment, more complete information, better outcomes. The last thing we all agreed on is that the healthcare system in and of itself is probably not well equipped to provide that level of balance and guidance given everything a physician does in a day and everything a healthcare professional does and the level of coordination in the system right now. So the idea of knowledge came up a great deal. The concept and the importance of hope did not come up as much, but obviously knowledge and information and the ability to make things happen for yourself are the things that breed hope. Today, we're going to focus on 2 possible sources of hope for the patient for outside the healthcare system. As I said, I don't want to focus on drug or diagnostic development per se, because those people are heroically striving to do everything they can as fast and as well as possible. And Stephen spends a bunch of his life trying to get folks into clinical trials so we can learn more about new drugs and diagnostics all the time. And the rest of us support that in different ways. Now, I think today we're going to take a look at two groups that have the ability and the tools to have more direct impact on hope, starting, say, tomorrow morning at 9 o'clock, if they were to really put themselves to it. One of those groups, information entrepreneurs, the people who create the apps we've been talking about for the last few weeks, and the other kinds of products that get patients the information they need at a more timely basis and provide them more practical help than, hey, you go lose weight. Second group, government agencies who are responsible for funding, gateway for drugs and diagnostics, and where patients get information about what they can believe in is possible for their future. Personal note, I was diagnosed with melanoma 9 years ago. There were no drugs at that time. My wife asked me what that meant, and I told her it meant I needed to stay alive long enough for the drugs to catch up. 3 years later, we had PD-1s. I never needed a PD-1, but if I did, they would have been there. A lot of drug development and government and hope is about knowing that if you do the right thing long enough, even if things get a little bit worse, hope's on the way, and hope takes the form of things the government will let happen. So, information entrepreneurs, how can they help us? Government, how can they help us in terms of providing hope and getting us tools? Same format as last week. I'm going to ask the patients and advocates to talk first. The rest of us will ask questions. Wayne, let's do the information suppliers first, and let's start with you.
Well, I'm an electrical engineer. I started writing programs in 1960. I spent my whole career in this rapidly changing computer world. And so if I was to talk to an app developer today, I have to think about it in terms of not really what we know how to do today, because, the doubling speed of knowledge is so fast right now that if you're going to create something that will be useful a year from now, you have to really be thinking about tools and methods and things that are just a glimmer to us right now. So I imagine when we think about apps right now, there are things that we connect up to our watches and we have them on our scales and we feed it information and it gives us things back. But with computer horsepower being, as a practical matter, almost infinite and almost free, we would have the ability, for example, to have an implant that gathered information about us continually. Maybe it's glucose powered, so we don't have to deal with batteries. But as we look about the future in a few years, we'll be able to have tools like that can report to us about important things continuously without us having to key it in and go to a lot of trouble. So when we think about apps, it's kind of like the whole smartphone thing has transformed society in 20 years. In another 10 years, we'll see more progress in sensors and tools and the whole process of AI and the information age is really upon us. So the challenge to the app developers today is to not think about what we have right now, but how do you integrate something when you have really powerful communications capability and high speeds and universal full-time access? That's a real challenge because we don't really teach people about those things yet. But that's really what we face when we talk about apps, because 10 years ago an app was kind of an interesting thing and there were a few, and now there's millions and they're throwaways in most cases. So we're looking for system level, broad, smart, always connected kinds of things. I think that's our future.
Okay, Wayne, thanks. So that's the 5-year out picture. Donna, is there a 6-month in picture?
There is, and Wayne is absolutely right, though, about where this is all going, and this is actually one of my favorite exercises to do, having visited a lot of tech incubators around the country in some of my earlier e-patient days, and spent a lot of time at places like Stanford Medicine X, which is a great combination of design, medicine, and business entrepreneurs. And in fact, we're meeting with some innovation folks to use human-centered design for a GLI project later this week. So when I think about an app for NASH patients specifically, and I say this as somebody who has wearables on both wrists, and has gone through testing several. I agree with Wayne that ideally we would have an implant, because the passive data entry is a really important thing. People get tired of entering, bits of information, and so that gets tedious, and it's a reason for most of the drop off. People uptake a lot of health apps very quickly, but the drop off is even steeper if possible. And so that passive data entry that Wayne spoke about is really important. I would say the ability to personalize metrics for people, so that you're not looking at a whole bunch of fields or requests to track things that you don't care about. So like if blood pressure isn't my issue, take the blood pressure off, for example, and add cholesterol or something else. If I only want to track macros but not my blood sugar, not my sugar specifically in my diet, take that off and put fiber in its place, for example, if I want that. Then having some type of live expert contact. Both Stephen and Louise spoke, so eloquently and so correctly about the need to, and so did you, Roger, the need to, tweak someone's understanding and the regime, help to respond to the challenges that they're having in between doctors' visits. And so having like a live video chat feature, I think, is important, so that people can have some of that contact and that help keeping on track. Resources that are customized, so not just generic, this is how you diet, or whatever, this is why your weight fluctuates or something, but something that as you start entering data and it starts learning you, so a little bit of AI behind it, with addition of some hand curation, but increasingly customized insights and comparisons both to yourself and others, trends line, and then resources, articles, or what have you, that are customized to you. And then, I think the final feature, having a social or community optional. So many people find comfort, reinforcement in that. I do not. I'll just be upfront. I've never gone to a support group that I wasn't speaking at, so I turn those features off on every app I have. So, but it brings, the literature shows and people reflect, it does help so many. So having that social optional feature, I think, would be part of a successful app, in NASH. And then I also think that an ability to, interact with your clinical information, and feed some curated, formatted part of what's been going on, in this lifestyle into your medical record would be the final thing I would ask for. So there's some interactivity between the lifestyle and your life outside the doctor's office that can inform your doctor, and that your medical records do inform some of what you're doing outside as well.
So I'm going to ask for questions. I just have a quick question, which is, who would have to provide that app for it to be HIPAA compliant?
Somebody who has a lawyer who understands HIPAA, which are more interesting, more easily found on the East Coast than on the West Coast. I have found in talking to entrepreneurs. So it's really not that hard. The rules are both more stringent and less than they're commonly interpreted. And as a patient, when you invite that information in, a patient is not a covered business entity. And so it's not really as arduous as people make it out to be.
Great. Okay. Louise, Stephen, questions?
I think I was interested to hear about what was potentially in the future and what they were both saying. And I was thinking in timeline, has COVID presented healthcare and with app development at the right time with an opportunity to do what Donna was saying, that we can get this information and start to integrate it with patients' health records, because patients have health concerns and well-being concerns 24/7. And I think that's an excellent idea, that allowing certain apps to be not so much given access to patients' records, but patients' medical records having access to the data. Now, we do know there are some very good cardiology apps and intensive care stuff that works very well and traces patients and alerts them if their heart rhythm is out of sync. And I think being able to feed that information and use technology now, post-COVID, patients don't necessarily want to go to hospital as much. They want diagnostics out in the community. And I think being able to track that on apps, even now, might be a benefit to be able to add to healthcare currently.
Louise, I think you're absolutely right. I think the biggest thing is changing physician comfort level with telehealth, with digital information. I remember, several years ago being asked by a physician to come in to have my blood pressure checked. It was sort of during an episode that we've been dealing with over the course of a few weeks. And I'm literally editing a white paper for the HIT policy committee, and I've been, taking my blood pressure using, a digital cuff and uploading, and happy to send him, my numbers and my, trend lines and things like that. And the thought that he was going to have me come in so he can, poof, 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 take my blood pressure was patently ridiculous then. It is even more so now. I think the difference is now that there has been a COVID transformation, more doctors are recognizing that it's actually unnecessary. And I think that familiarity and comfort level with patient data taken from home, which might not be absolutely accurate, but maybe internally consistent and calibrated within and of itself, and maybe well sufficient for most tasks. And having those conversations by different mechanisms, and really being thoughtful about what is the threshold or what are the circumstances that would make it an in-person visit necessary. That's the thought process that we've needed to jumpstart a lot of digital applications that have been available for so long. So I agree. I think COVID has advanced a lot of digital and telehealth applications, and hopefully we'll make them stick.
Well, if you think about the rate of change that's going on, what we really will get to at some point is that the medical record will really follow the patient. It'll be the patient's medical record, and we won't have this fragmented silo problem where doctors may or may not communicate about important things. We will allow doctors to have access to our medical record, and it'll follow us around just as part of our digital life as it's recorded by the ever-present internet. But that kind of process, I think, is in our future once we get past the lawyers and the reticence of doctors to let that information not be under their control.
This is Stephen. I'll just say I really like what I've heard today. Using apps to perform integrated health sensing would be amazing. And if we could power it off glucose, that would be awesome. But maybe even powering it off the fat we have floating around would be even better. I also like this idea of a live video app feature and what I would call Peloton for life. If you've ever done Peloton, you've got this person yelling at you, stand up, go faster, slow down, take a deep breath, you can do it. Imagine having, something you push every morning when you wake up and you're getting your cup of coffee and it says like, good morning, you're awesome, resourceful, fearless, and persistent in your efforts to follow a healthy lifestyle. You can do it, and it's tailored to you, right? You really like that donut. I know you do. Put it down. Put it down. Go for the fruit. Go for the yogurt. You can do it. And like you're just motivated for life throughout the day, and maybe it's integrated into your watch so that when it's time for you to typically eat lunch, it's giving you a little reminder. I love that idea. At the end of the day, you have different motivations for different people, and some people are easily motivated. I can tell you, having a 20-year-old, some people are very challenged to get motivated to do certain things. I think finding unique ways to really get at all of the different phenotypes that are out there and motivate them to do the things that we know they can do is important. I tell my patients all the time that unless you have alien physiology, if you burn more than you take in, you will lose weight. And, I have people all the time that tell me, oh, that's not true, Doc. I eat like a bird and I still can't lose weight. And I'm like, well, I can't go home with you, but I guarantee you that, if you burn more than 3,500 calories than you take in, you will lose a pound. It's just really that simple. So anyway, I agree with what's been said. It's now the next pragmatic step is how do we get there? But those are great thoughts for sure.
So a couple of observations and then a question. First of all, personally, I found that logging food intake, probably the most helpful single thing I learned to do. I've lost 100 pounds over the course of my life, 50 once and 25 twice. And the last time it stuck, or at least it stuck for 2 years, knock on wood. And I intend for it to stick the rest of my life. But logging has been a huge key to that because, and it's a logging app actually that informs me not just how many calories I'm eating, what's the quality of the food and kind of what is it, and is it healthy for me to be eating that much? So that I can self-manage my diet and I can actually watch how my weight changes as I do things right, or more commonly as I do things wrong and scare the stuffing out of myself. That's an easy app, and there are a bunch of those out there right now. But what I'm listening to us talking about is working with individual patients, maybe within a digital health record as Wayne defined it, to help them interpret their own data and their situation, provide some guidance, some cheerleading, maybe some behavior change. I'm envisioning how that works in a world with too much litigation. And what are the steps that advocates should be taking now to ready the world for that moment when you don't want the first person who claims they did it right and still gets sick to go to a lawyer who throws a class action suit in front of 30 million people on television every day. Do we have the ability to start changing the rules on that now?
Yeah, Roger, I just don't think that's the scenario. That's not the barrier. I served on, as a GAO appointee to the Health Information Technology Policy Committee, advising the Office of the National Coordinator for HIT. The threat of litigation is not our barrier. I think health systems looking at our health records as business assets is a barrier. That came out when we were discussing at the National Academy of Medicine, even more recently than my HIT policy experience. The fact that there are 100 different ways to record HbA1c in a medical record is a barrier for young entrepreneurs to be able to overcome. The business model, you see, free versus premium services. So the business model, like why did Google Health its health or Microsoft Health Vault and other things, fail when they were trying to bring all these pieces together, didn't quite achieve platform effects. Those are the barriers. It's not people can't figure out HIPAA, which is actually, pretty limited, or worried about lawyers because you're not actually making medical judgments or decision making. You're giving, reflecting back, information that people are opting into and sharing with their physicians to make the actual medical decisions and have the insurance, liability to cover their medical decision making. So speaking as a lawyer and defense of lawyers, this is not one of the issues that we are standing in the way from. We were responsible because I guess of certain clients for gag clauses, not allowing hospital executives in the old days to talk about how bad their EHRs were. So for that, I say tis to my legal colleagues and to the hospital executives who allowed them and who felt compelled to sign those. But it's not a legal or a litigation issue, Roger. It's just not.
So well argued, Counselor. That being the case, what can we do, and whatever our roles are, to make it easier for those kinds of data integration to happen? I mean, if Google can't get it right, or has challenges, and if Microsoft has challenges, then what can people in any of our roles do to help make it work better?
So it wasn't that they couldn't get it right. The actual product had a lot of value. But in the past, at another advocacy organization, I set up a very successful innovation day and gave a forum to entrepreneurs we defined problems that matter to patients in the liver space. We identified some entrepreneurs who we were meeting with and invited some health systems and physicians to rate them, and we had some really high quality matching. And so I'd love to bring that type of program into GLI in this day and age, certainly with all I've learned since then, and even more importantly, have the funding, a foundation grant to really have a focus group of NASH patients. Talked about the digital health force that we're developing NASH patients for that user experience testing that's so necessary, to really work with entrepreneurs to define their problems and tell them, what they would value and find useful, and to do that type of, we used to call it Health Data Palooza, and design challenges, sprints, and that would be really exciting and fun to do for a NASH specific digital technology or platform. We'd love to host that.
Why don't we move on to the other half of the agenda, which is in the context of hope and knowledge, what we want, what we need from government agencies. And Donna, since I tossed Wayne the last one, why don't I toss you this one?
Okay. From government agencies, I think that there is so much more, and I'll speak from the U.S. Perspective, although there is a lot to be done to have NASH recognized as a public health challenge by the WHO as part of our, sustainable, goals to be able to achieve. With 500 million people affected by liver disease, liver as a whole needs to be elevated, and liver health as a whole needs to be elevated on the global public health agenda. But in NASH specifically, and in the U.S. specifically, let's start with research. So NIDDK, their strategic planning process is open right now. And so it's an exciting opportunity to set them up for the next 5 years. I do believe the liver branch could be even stronger and even more focused on not just basic research, but also the translational research. We'd love to see, a cross-NIH, cross-institute NIH plan for liver disease, so that NIDDK and NCI and NIAID, that's the famed Tony Fauci's institute, amongst others, would work even more collaboratively to have a very proactive liver health research agenda. So that's one. We've been working to put a spotlight on CDC so that there was it was structured in a way that could give GLI, but give the liver community a more comprehensive state of the liver health. So right now there's siloed viral hepatitis, does a lot of great work, cancer control and prevention, but there's obesity, and we're not really sure that there's a connective tissue that they talk to each other in the same way that the liver talks to every other part of the body, and is able to provide us the data with which we can understand the scope and scale of liver problems in the United States and be able to program effectively. We talked about CMS earlier, and we've certainly been working with CMS throughout COVID on a variety of things, waivers for telehealth and hopefully waivers for prior authorization and things like that we've worked on with AGA and ACG. And I think it is well known by now that our eyes are on FDA and the hepatology and nutrition division, as we have stated very clearly our expectations for transparency and patient engagement, particularly around benefit risks with the patient community with that division. And finally, in Congress right now, well, first of all, I hope that they support the post office so we can have a democracy. But we also have our Liver Act, and we're supporting of the acronym is TROA. It is a Treat and Reduce Obesity Act, and so that and the Liver Illness Visibility Act are both something that are eligible to be incorporated into hopefully whatever next package goes along, or as standalone bills. And so we really do have there's a large lift for the federal government and all of the health-facing agencies in how they start to recognize liver health and liver patients. But I'll stop talking for a moment. I'm passionate about these issues, and I just got 2 liters of fluid, so everything is starting to really kick in.
Passionate and wired. It's a great combination. Wayne, why don't you supplement, please?
Oh, my Roger, can you imagine following that?
No, that's why I asked you to do it, Wayne. Thanks, I don't have to.
Donna is...
Nothing better than passion except obsessed passion, as I've talked about before. When you're obsessed with your passion, there's only amazing things can happen. The problem is those around us have to rise to that level of passion to even be in the same league. So Wayne, I know you're up to the task. So
well, thanks, Stephen. We actually, the foundation is focused on we're a rifle shot on NASH, but we're really a society-facing operation. Our concern is the public health. Our goal is to put doctors out of business by solving this problem of obesity. So as I think about the government, our focus would be on HHS, because their charter is to deal with, our health, our safety. And, we have this epidemic of obesity, and if we really believe we have an epidemic, you would think that we would deploy resources to deal with it. As patient advocates, or as people advocates, it's offensive to us that so much of our population is underserved in terms of insurance, in terms of their ability to have proper food, by their ability to even have proper counsel on the part, coming out of the federal agencies. The USDA guidelines over the past decades has led us to, it certainly contributed a lot to the way that we're experiencing this disease. So the whole concept of having an HHS department that acknowledges that we are dying in droves because of preventable lifestyle diseases, and we do things like pay to have more sugar. We do price supports on sugar. How crazy can you be if you care about health? Those are the kinds of population-facing things that we really care about. I can't even have an intelligent conversation with Donna about the internal workings of the government because it's just beyond me. But from abroad, we really need to think of this as public health and a societal, generational problem, and to put the resources into it that can make a difference, and not just moan about the fact that people are fat and don't lose weight.
So, Wayne, I have a hunch that Louise is about to tell you that all you need is an obese prime minister with COVID-19 and the world changes. Louise, why don't you go ahead? I'm guessing that's where you're going. I could be wrong.
I wasn't, but I think obviously with COVID-19 we did have one of the world leaders quite severely affected, and I think where we've now got some action, whether or not people agree with whether that action is correct or incorrect, whether or not it's obesity shaming, whether or not it's challenging people's lifestyles, I think the debate is welcome, and I think lots of people have different views on it, and I think that they all have to be listened to. Obesity is a complex condition, and we were talking before we started about where does obesity become a disease, and some people would agree with that, some people won't. But what Boris Johnson had the benefit of being was relatively healthy. He plays tennis, is my understanding, he cycles, and I feel that that was probably one of the reasons his respiratory condition stayed where it was, because he does have that level of fitness, whether or not it's the weight and therefore other conditions that have driven him to decide on an obesity strategy. I don't know. Is it the best one in the world? The Canadians have just come out with one that, from my understanding, what I've read briefly, is a little bit more robust. So it'll be interesting to see where it goes. They are using an app. I did look at the app. It was only for people who were overweight. And as we appreciate, we've discussed on the podcast for numerous times, that there's an awful lot of people at risk of potentially COVID-related fatty liver disease effects, if the UK Biobank is to be believed, with their 10% liver fat increasing the severity of COVID and the mortality rates. I think it rules out anybody who has lean NASH. It rules out people with lower BMIs in different ethnicities sometimes. So bringing in apps can be effective, bringing in where we want to go in the future. And I was interested in Roger's point of litigation, and I wonder whether or not we're more likely to see people take that power and go down the route that they did with smoking, whereby you turn around and eventually say that you could have made your burger 500 calories less and you chose not to. The same way with tobacco, that you could have made it low nicotine, you could have made it less nicotine, it becomes less carcinogenic. Whereas when we deliberately put food out there that is so high calorie that it causes problem, where does the ethics of what industry is doing and turn round, and when do people turn round and say, actually, you are damaging my health. Yes, I have a choice to eat it or not, but you're putting it there at a dangerous level of sugar, of corn syrup, of those things that damage. So I think there's a bigger debate than just Boris Johnson being overweight and introducing things.
These are great comments. I would echo everything that's been said already. I don't have a lot to add on top of that. I do foot stomp what Donna said about the FDA and the need to provide a transparent, clear review process, what that means, what's required, what's needed, what's superfluous, so that we can all work towards those aims and give them the data that's needed. Maybe I'll just stop there.
Can I just ask a question? I just wonder whether sometimes our health services are set up so complex rather than keep it simple. We have multiple stakeholders in any single disease. From here, and I'm not an overt expert on this, we have Public Health England, we have the NHS England, we have NICE advocating. And if everybody is split, do Donna and Wayne find that weakens the argument when you try to take a case forward, or does it strengthen it?
It does make it harder, Louise, and that's why advocating for a cross NIH liver research strategy, for example, or better interdivision communication, or even a liver health task force within CDC, is to reduce just that type of complexity, or at least to force some type of coordination and regularize some thinking so that assets across agencies or entities can be deployed. I think that, and I want to people to know I can speak very positively about FDA. And so, FDA long ago created an FDA CMS working group so that, once things were approved, paying for them was a more seamless process. And so I think, things like that do have great outcomes for for health and public health, and even greater joy for the people involved who do want to solve problems and are often sort of caught in traps of their own making, or of sometimes congressional or authorizers making. And so that really is essential function for GLI, to see where there are either systemic breakdown or duplication, and where things can be made more efficient and more seamless, both within the liver advocacy community itself, so we can get on the same page. And I think we've been pretty successful at that. And so how can we help our government entities work better together? And so I think the U.S. NASH action plan that we are developing to make it more clear about what actions would be helpful for patients, for providers, for payers, for policymakers, and for for regulators and others, is an attempt to help reduce some of that complexity, or at least give people a pathway to see themselves through it.
We're going to let that be the final word. Donna, I've noticed since you've joined us permanently, final word winds up frequently with you, but that's because you sum things up so brilliantly. Thank you. Maybe it's legal training. Maybe it's just this is what you do for a living, but it's really great to have you doing this. All right. With that, moving to final question. One thing you heard today that surprised you.
I'll be the brave one today. The thing that surprised me was Donna was able to get the CDC to ICD-10 codes changed to identify that there are differences between lower grade disease and higher grade. So congratulations again.
Got a couple things that surprised me. Number one, I did not realize that Boris was obese, but I'm glad he recovered. The other thing I was surprised about, well, actually, it was a comment Wayne made that I found very, very interesting, and that is powering these sensing devices with glucose. That's really novel. I mean, what better way to generate information about our bodies than to power it with the same thing that would help us get in better shape by burning off fat or glucose? And then, of course, the comments that were made in reference to ICD-10 coding will help me for sure in clinic, and I'm glad that was done. And I'm also pleased with Roger's comment about meeting people on his vacation and spreading the word about NASH. And I think what that shows us is that people just need an avenue, a conduit to begin a conversation. Everybody has patients or everybody has experiences where they run into people where this same story gets told over and over again. Wayne mentioned it at the top of the hour. Roger, you mentioned it again today. I know Donna's mentioned it and Louise several times in the past. We all have these experiences. And I would just encourage people to go out and have open dialogue about that with everybody they see, and refer them to the podcast, because they'll learn a lot about NASH and what's going on in the field by listening in to the 19 episodes.
And that's a function of all of our obsessed passion. Thanks. Wayne?
I was amazed at the in-depth review that Donna did about the government. It was really awe-inspiring. So I got to take my hat off to her. I wouldn't have thought anybody could do that in such a short period of time. But it illustrates, just how difficult a situation we have, because we got all these departments and they've all got their agendas, and my goodness, it's a wonder we get anything done at all.
Couple thoughts. First of all, I'm going to surprise myself by using a word I've never used in my life, or even know that I've heard before this conversation. I want to foot stomp Louise and Stephen's praise of Donna's work on the ICD-10 codes. I didn't even know that was going on, but that's a fantastic thing. And the fact that I'm using the word foot stomp is quite surprising to me in its own right. Wayne, I love the idea about glucose. I love the idea about, there's something fantastic about being able to take the solution to the thing that you have to do for your body and with your body and make it part of how you learn about your body. There's a circularity to it that's amazingly elegant to me. So I think those are my surprises for the week, and they're all good and upbeat and positive things. All right, I think we could talk about this subject for hours. We probably will come back to it again fairly soon. If you want to talk about it, listeners, if you want us to talk about it in specific ways, or if you want to pose questions and get answers, go to the discussion groups, and we'll pick it up. We'll talk. We'll answer. We'll send those questions where they need to be. We'll get you what you need. Again, if you want to catch up on what we're doing next week on EASL early, get us your email address so that we can send you the updates as soon as they're available. We will be, as I say, covering with a preview on kind of what to expect on Thursday. That will drop Thursday. And then session reviews on Friday, Saturday, Sunday. Wayne will have his shortly thereafter. Thanks to our engineer, Mike Wilson, who does such a good job of pulling this together. The distribution folks at Buzzsprout, who've been so easy to work with and good at providing data. Eric Rounds, our social media master, who comes up with new things all the time. Paul Teolay, who makes everyone's microphones go. Ryan Segura, our editor. The Surfers. And Wayne, you guys are always fantastic. Today, I think you even went above and beyond. And thanks to the listeners who help us as we continue to build this podcast. We'll be back with you next Thursday with what to expect from EASL, and we will be 20 at that point in time. Oh my gosh, teenagers no longer. Please enjoy the music from James Ramsdale on the way out. I've gotten to listen 3 or 4 times. It's magnificent. Stay safe, surf on. See you next week. Thank you.